Good morning, everyone. Welcome to the first talk in our new diagnosis workshop series. Today we have movement disorder specialist Dr. Jonathan Squires speaking on what is Parkinson's disease. My name is Alana Dillon. I'm an Education and Support Services Coordinator at Parkinson Society BC, and I will be facilitating the webinar today. Before I introduce Dr. Squires, I'd like to go through a few housekeeping items. First, I want to let you know that we are recording this webinar, and it, along with the presentation slides, will be available on our website. Secondly, you will see a chat icon at the bottom of your screen. You may click on that to open it up, and feel free to use this chat box during the webinar to make any comments or questions on today's presentation topic. And Dr. Squires will address questions at the end of his presentation. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume both on your computer as well as on your actual speakers so that you can hear the webinar well. It's my pleasure to now introduce Dr. Jonathan Squires. Dr. Squires is a movement disorder specialist and co-medical director at Pacific Parkinson's Research Center, as well as a clinical assistant professor at UBC. Dr. Squires, thanks for joining us today, and I'll pass it over to you now.
Great, thanks, Elena. Welcome, everybody. Thanks for coming today. I'm just going to put my slides up here. We are going to kick off the latest new diagnosis webinar today. If you tune in the next couple of weeks, you'll also be hearing from colleagues from the clinic, Joanna, our great nurse practitioner, and Michelle, our physiotherapist. This is the overall outline of what we're going to cover over the next couple of weeks. So as Alana mentioned, I'm going to start off with an introduction to what Parkinson's disease is, what we understand about what causes it, how common it is, how it's diagnosed, and some of the symptoms. Next week, Joanna will go over the management of Parkinson's disease, and then Michelle will give everyone some practical tips on how to live well with PD, and then there'll be a longer question and answer session in 2 weeks' time. So diving right in, Parkinson's disease has been around for a long time. It was actually first described by James Parkinson in 1817 in this book that he wrote called An Essay on the Shaking Palsy, which was basically his observations of people that he observed sort of walking through the streets of London back then. So we've known about it for a long time. So what is Parkinson's disease? Parkinson's falls in the family of what are referred to as neurodegenerative conditions. This is a group of disorders that includes things like Alzheimer's disease and ALS, where the common characteristic is that certain populations of brain cells are slowly dying away. In most cases, we don't know what causes these brain cells to die away. In the case of Parkinson's disease, the population of brain cells that we mostly talk about are those that are involved in producing a neurotransmitter called dopamine. And if you look at the brain cells under a microscope, you see accumulation of these abnormal inclusions that are called Lewy bodies, which are basically clumps of abnormal protein. And we think that something about these abnormal proteins are toxic to the brain cells and causes them to die away. But we don't know in most cases, we don't know exactly what causes these proteins to accumulate in the first place. So dopamine is a neurotransmitter or a chemical messenger that brain cells use to communicate with each other. It's got a number of different roles in the brain. In terms of Parkinson's, we focus a lot on its role in the control of movement, particularly in initiating and maintaining movement. It's also involved in mood. It's one of the good mood neurochemicals, along with serotonin and norepinephrine, and more on that later. And it also has a lot of other functions. So probably the best known is its role in the so-called reward pathway. So it mediates pleasurable responses to things. It's also important in addiction, which also has some relevance in Parkinson's disease. So in terms of what causes PD, we still don't really know. 200 years plus after it was first described as an entity, we're still working to figure that out. We do know now that up to 10% or so of cases are genetic. So there are more than 30 genes now that have been identified that are strongly linked to Parkinson's disease. Most people with genetic subtypes of Parkinson's tend to have younger onset, so usually before age 50. And basically a good rule of thumb is that the younger someone is when their symptoms start, the more likely it is that there's a genetic cause underlying it. So if you see the odd person in their, even the teenagers can develop Parkinson's disease, those people are almost certainly going to have a gene identified. Most people with genetic forms of Parkinson's disease have a strong family history, so multiple affected family members over multiple generations. There are what are called autosomal recessive causes of Parkinson's as well. So what that means is that you need to inherit a copy of the abnormal gene from both parents in order to manifest the disease. And in those cases, there may not be a family history, but pretty well all of those recessive causes of Parkinson's, the onset is very young. So usually before the age of 40. We do know that if you have an affected first-degree relative, so a sibling, a parent, that it approximately doubles your risk of developing Parkinson's. Many people in that case don't have an identified gene that is causing their Parkinson's, but we presume that there's an underlying genetic risk that increases the likelihood that you'll get Parkinson's disease. So of the risk factors that we know about, age is really the biggest risk factor. So Parkinson's disease affects roughly 0.3% of the whole population. If you consider people who are over the age of 65, you see about 1% in that age group are affected. And then if you look at people over 80, it's around 3% of people who are affected. And so it does become much more common as people age, though still relatively uncommon. Men are more likely to get Parkinson's than women. It's about a roughly 2/3 men, 1/3 women, if you look at the population of people with Parkinson's, all told. Having a history of recurrent head injuries. So this is sort of many head injuries over the years, like boxers, maybe professional athletes, for example, are more likely to get Parkinson's disease. For some reason, living in the countryside, you're more likely to get PD than if you live in a city. And this may be related to exposures, for example, potentially pesticide exposure, potentially heavy metals in the groundwater. So people who drink from a well are more likely to get Parkinson's than people who drink from a municipal water supply. And then family history, like I said. So having an affected family member roughly doubles your risk. So like many things in medicine these days, at the end of the day, there's a small percentage of people who have a gene that's causing their Parkinson's disease. For most people, we assume that there's some kind of underlying genetic risk that we haven't identified with certain environmental exposures, perhaps at critical times in brain development. And some of these exposures may be quite remote from developing the symptoms. So for example, I've had a number of patients over the years who would, grew up in the city, but went off to the countryside to stay with grandma and grandpa in the summertime on the farm. And the pesticide truck would be going down the street with the fog of pesticide behind them, and the kids would chase the truck and play in the fog. Now, that might have been 50 years before their symptoms start, but you've got to kind of wonder that might not have been the healthiest activity for their brain growing up. So it can be really difficult to definitively link events like that when they might be separated by decades. So there's still a lot of speculation, unfortunately. So how common is Parkinson's disease? So among the neurodegenerative disorders, it's the second most common after Alzheimer's disease. Now, Alzheimer's is much more common than Parkinson's disease, but we still estimate that around 13,000 people in British Columbia are affected by Parkinson's disease. Now, these were estimates from, as you can see, from 7 years ago. So the number is likely a fair bit higher today by maybe a few thousand people. And similarly, it's estimated that there's about 100,000 people in Canada who have Parkinson's disease. And this is data from the Public Health Agency of Canada looking at the breakdown. So you can see that the prevalence really increases as people age. The prevalence of Parkinson's, which is how many people are living with Parkinson's, is increasing. And faster than Alzheimer's disease, actually, which seems alarming, but I think some of that is that we're probably a bit better at managing Parkinson's than we used to be, and so people are living longer with Parkinson's. And you can see there's not that many people who are younger with PD, but roughly 1 in 7 people with Parkinson's will have their symptoms start before they turn 50. Okay, so now, knowing a little bit about what Parkinson's is, how do we diagnose it? So Parkinson's disease is still diagnosed clinically, which means we take a history talking to you about what your symptoms are and then do a physical exam. And based on that, we have diagnostic criteria. So the way that Parkinson's is diagnosed is first to establish whether you have Parkinsonism. So some of you may have heard, Parkinson's disease versus Parkinsonism, and what's the difference between them. So what Parkinsonism is basically a collection of symptoms, and it can have many different causes, of which Parkinson's disease is the most common. So Parkinson's disease is the most common cause of Parkinsonism. Great, so what the heck is Parkinsonism? So Parkinsonism is defined by what's called bradykinesia, or slowness of movement. That is the hallmark feature of Parkinson's disease, and if you do not have this, you do not have Parkinson's disease. So that slowness of movement manifests in lots of different ways. So it can be, basically everything gets slower and smaller. So you get a soft voice, your handwriting gets smaller as you go, the face is less animated, your walking slows down, your fine finger movements become slower and clumsier. So that's really the defining feature. And then in addition to bradykinesia, you have to have one of increased muscle tone or rigidity. So when we move your limbs around, there's more resistance to movement than we would expect, or a resting tremor. So we break tremor down as to in which circumstances it's at its worst. So is it worse when you're relaxed? Is it worse when you're using your hands? With Parkinson's disease, the tremor is generally worst when you're completely relaxed. So your arms are lying on a table, muscles are not activated at all. That's when the tremor will come out. And typically with Parkinson's, these symptoms start on one side. So first step, do you have Parkinsonism? Slowness with one of the other two. And then step 2 is to rule out other things that aren't Parkinson's disease, basically. So that's kind of it. And then people always ask, is there a test to confirm the diagnosis of Parkinson's? You'd think 2022, there's been all these terrific medical advances. Surely there must be something better than coming to see Dr. Squires and me watching you walk and telling you have Parkinson's disease. Well, there is a test to confirm the diagnosis. It's an autopsy. And that still is the only test that we have that will prove that you have Parkinson's disease. I can tell you it's not a popular option in my experience. Otherwise, other testing that we have routinely available, so MRI and CT scans of the brain, they're typically normal. There's nothing really that would show up that would tell you have Parkinson's disease. As we'll talk about in a minute, some of the mimics of Parkinson's disease can have telltale findings on an MRI, but even those findings might occur late in the disease course when the diagnosis really isn't in question anymore. At most, what you'll see is loss of brain volume, so shrinking of the brain. And that happens to us all as we get older. I think once you hit 30 or 40 or something like that, your brain starts to shrink. So sometimes if you have a neurodegenerative disease, you start to see a bit more shrinking than you might expect for someone of that age, but it's a very non-specific finding. There are some more specialized tests that look at brain function rather than brain structure, as you see with MRI and CT. So there's this special type of PET scan where you're injected with a radioactive dopamine analog, and you see what parts of the brain take it up, and that can be abnormal with Parkinson's disease. And there's also what's called a DAT scan that's been available for a long time now, but was only just approved by Health Canada about 2 years ago, and that labels the dopamine transporter system. And for people with Parkinson's disease, the dopamine transport system is affected. Neither one of those tests are terribly specific for Parkinson's disease, so they can be abnormal with some of the mimics of Parkinson's disease as well, and are not often that helpful and not often used. A DAT scan, which we don't have access to fluorodopa PET, it's really a research tool at this stage. We do have access to DAT scans, but they don't usually offer a lot. When you study them, they're about as good at diagnosing Parkinson's as being assessed by a neurologist who knows about Parkinson's disease. So not something that we tend to order. Even, I spent a year training in the United States to specialize in movement disorders, and even there, where tests are much more routinely done, I didn't order a single DAT scan in my time there because they usually don't add all that much. So if you don't have PD and you have Parkinsonism, then what the heck do you have, right? So there are a number of other things that can mimic Parkinson's. Most commonly, there's a group of other neurodegenerative disorders that are less common than Parkinson's, but can be completely identical to Parkinson's, at least in the first few years. So most times, if someone is misdiagnosed with Parkinson's disease, they have one of these other neurodegenerative disorders. As an example, the Mayo Clinic some years ago did a study looking at their accuracy of clinical diagnosis. And what they did was they started with a group of people who had consented to autopsy. So they've started by looking at the brain under a microscope, so they know what these people had. And then they looked back in their records and said, okay, well, what did we think they had when they were still alive? In the first few years in that study, they got the diagnosis wrong 30% of the time. At the time of death, now that would have been a different interval for everybody, they still had the diagnosis wrong about 10% of the time. And the majority of those people had one of the other neurodegenerative disorders, most commonly a disease called progressive supranuclear palsy. Other things, fairly common medications. So antipsychotic medications work by blocking dopamine receptors. And those are often used for people with other mood disorders as well, schizophrenia, bipolar disorder, sometimes people with severe depression or anxiety. So those can cause similar symptoms. And then there's a few other medications, one or two nausea medications, and a few other things here and there that can cause Parkinson-like symptoms because they block the dopamine receptor, but they don't cause Parkinson's disease. They cause symptoms that will resolve if you stop the medication. And then rarely people will have another structural problem of the brain. So if you were to have a stroke or something, a tumor, something like that, pressing on just the right part of the brain, you could end up with symptoms that look a lot like Parkinson's disease. That's very rare. I've never actually seen anyone within that circumstance. So we talked a little bit about how accurate the diagnosis is. So just important to know when you're seeing a neurologist early on in the disease course, generally speaking, by 5 years in, if you've got something that's not Parkinson's, there are fairly good signs at that point that make us comfortable. We're always on the lookout for things that we don't expect that might point to a different diagnosis. So we have a pretty good idea of Parkinson's progression, and if certain symptoms crop up that we only expect after you've had Parkinson's for 15 years, but you've only had Parkinson's for 2 years, that makes us question. Nothing is good enough to be definitive, but we're always keeping an open mind about the diagnosis. Now, having said that, the mimics of Parkinson's disease tend to be worse things to have than Parkinson's disease. So we always, kind of hope that we're not wrong in a way, unless it's around medications. But the other neurodegenerative disorders tend to be more rapidly progressive and don't respond to treatment. So people often wonder how their condition will progress. That's probably the most common question that I get from my patients. So in general, Parkinson's disease progresses very slowly over years. So even people with more aggressive Parkinson's who who have what we would consider to be rapid progression are still showing progression over years, not months. The rate of progression, however, is highly variable from person to person. So I have patients who've had Parkinson's for 15 or 20 years who are doing as well or better than some of my patients who've had Parkinson's for 5 or 6 years, right? So it's really a big spectrum. Most people fall in the middle. One thing that may offer comfort to some is that while progression is very different from one individual to the next, it tends not to change all that much for a given person. So if you're progressing at a rate sort of like this, you're not all of a sudden going to fall off a cliff and progress more quickly. It's really kind of slow and steady over the years. Now, in general, women tend to progress more slowly than men. Not really sure why. The younger you are when your symptoms start, in general, the more slowly your symptoms will progress. One important thing to note is that if your symptoms suddenly get worse, like you're kind of doing okay, and then within a day or 2 or 3, things are way worse, like you feel like you've had 3 years of progression over that period of time, that's not your Parkinson's. That's generally a sign that something else is going on. So you've got a bladder infection, you're not sleeping well, you're under a lot of stress, severe anxiety, for example. It might be bad constipation, which impairs absorption of the medication. But generally speaking, a sudden drastic change is an indicator of some other stressor in your life, whether it's an infection, a psychological stress, other medical problems cropping up. So when people call us and say, "Hey doc, I feel I've never felt this bad before. This has happened really suddenly," we generally recommend people go to see their family doctor, nurse practitioner, whoever their primary care provider is, to do a medical screen and make sure that there's not some other problem intervening. So I've done a lot of talk about Parkinson's. So what symptoms do people get with Parkinson's disease? So we've got zebras and fingerprints up here, because just to point out that no two people are ever the same. You'll see a long laundry list of symptoms, longer than you are, that could come up with Parkinson's disease. But nobody with Parkinson's gets all of them. So just because you see something doesn't necessarily mean that that's what's in store for you. Everybody progresses differently. So we generally break down Parkinson's symptoms into motor symptoms, non-motor symptoms, and pre-motor symptoms. And we'll go through all of those. So the earliest symptoms are the pre-motor symptoms. So this is things that can show up before you have the tremor, before your walking slows down, what have you. And these can come up 15 or 20 years sometimes before any of those other motor symptoms begin. One is loss of sense of smell, very common and can happen 15 years plus prior to the onset of other things. Constipation is another big one. There's a condition called REM sleep behavior disorder, wherein people are acting out their dreams. So your dreams are very vivid and lifelike, like you're watching a movie, and then you actually start to act them out. So people may scream, kick, punch, thrash in their sleep. Again, can happen 15 to 20 years before anything else happens. And then finally, depression and anxiety. People who've never had issues with their mood in their life, all of a sudden they turn 50 and become anxious, right? And then that could be the first sign of Parkinson's disease. Now, these are due to buildup of the Parkinson's pathology in the parts of the brain that mediate these symptoms. And there's a lot of interest into looking at these symptoms as markers of Parkinson's disease. So when we finally get a cure for Parkinson's disease, ideally, we would administer the cure to people who are at this stage, right? When your only symptom is that you lost your sense of smell before anything else happens. So there's a lot of interest going on how to tell, someone who's 40 and constipated, quite non-specific, but is there a way that we can tell which of those people are going to go on to develop Parkinson's disease? Obviously, most people with constipation do not develop Parkinson's disease. So it's a bit tricky, but there's lots of interest there. So moving on to the motor and we'll start with the motor symptoms and then move on to the non-motor symptoms. So one of our frequently asked questions is, I don't have tremor. Does that mean I still have Parkinson's disease? So we'll go into that a bit more. So the motor symptoms of Parkinson's are tremor, probably the best recognized symptom, but important to note that only 80% of people with Parkinson's have a tremor. So there's still that, 1/5 of people with Parkinson's never have a tremor. So in the past, when awareness wasn't as great with Parkinson's, it was sort of said, well, you don't have a tremor, you can't have Parkinson's disease. We definitely know that's not true. And this recognition may account for the fact that at least in some parts of the world, it looks like Parkinson's is becoming more common, but it may just be with improvements in medical education and awareness that more people are being diagnosed for this reason. Rigidity, we talked about. So rigidity is when the limbs are stiff. That's not the typical stiffness that you might feel in your back when you wake up in the morning or things like that. That's when we move your limbs around, you start to feel more passive resistance because the muscle tone is increased. And that sometimes can contribute to pain. Bradykinesia, we talked about, it means slow movement. It's an old Greek word. Talked to some about those ways that can manifest. So basically everything slows down and becomes smaller. Really, the problem is you have trouble starting a movement and continuing a movement. So as you go, things will get smaller. So when you go in and see the doctor and we make you do things like this, what we're looking for is if you have bradykinesia, it will slow down and get smaller as you go. So it might start normally and then you get this decrement in the speed. And this is, gives much of the disability associated with Parkinson's. It makes things harder to do. It affects your fine motor control, dexterity, things like doing up the little buttons and brushing your teeth and shaving, and just really fine things become more challenging. And then postural instability is one of the hallmark motor features of Parkinson's. So trouble with balance, loss of those reflexes that allow us to catch ourselves when we're falling. This is something that we expect late in the disease course of Parkinson's disease. The non-motor symptoms are much more varied and significant. And as we've gotten better, most of the medications that we have for Parkinson's disease are really focused on these motor symptoms. And as the disease progresses, people tend to have more and more of the non-motor symptoms. And really, these are what impact people's quality of life the most when people with Parkinson's are surveyed. Again, there's many of these. None of you will get all of them. That is one thing that I can promise. Some of you may have many, some may have relatively few, but no one will get all of them. Mood symptoms are very common. So depending on what study you look at, anywhere from 50 to 100% of people with Parkinson's will have changes to their mood. Now, you may think, well, of course, I'm going to be depressed. I've got Parkinson's disease, and it's this potentially disabling condition. But we know that it's more than just the disability. So in the past, people have done studies looking at people with Parkinson's versus other conditions that are equally disabling. For example, rheumatoid arthritis, in the era before the current treatments we have, people could get quite disabled with it. People with diseases like Parkinson's had much more issues with their mood than people with equally disabling rheumatoid arthritis, for example. So it really is a core symptom of the Parkinson's, and it reflects partly the role of dopamine in maintaining your mood. And some people definitely notice that when they take medication for their Parkinson's that replaces dopamine, that their mood improves. However, it's more than just that. So we tend to focus a lot on dopamine when we talk about Parkinson's because it's the thing that we have the best treatments for. But other neurochemicals are affected in Parkinson's disease. We know that levels of serotonin and norepinephrine are low in Parkinson's, and those are the other two good mood chemicals that we just don't have good replacements for. And so other brain networks are involved as well that help manifest these symptoms. So depression and anxiety, I think a lot of people tend to minimize them, brush them off because it's like, well, of course, I'm feeling depressed. I have Parkinson's disease. But they are important symptoms and often major drivers of quality of life. So it's important to recognize and treat mood disorders. They can respond well to treatment. So we tend to use the same treatments for mood that people who don't have Parkinson's disease have. So mindfulness, cognitive behavior therapy, other forms of talk therapy, antidepressant medications. Joanna will talk more about that next week. And then other psychiatric symptoms arise as well. So apathy is very common, usually later in the disease. So apathy is sort of loss of motivation. You just can't be bothered to, I don't want to go see my friends. I don't want to go out for a walk. I just want to, sit and watch television. Just lack of motivation to do things. Usually this happens later in the disease. We often associate this with depression, this lack of motivation, but it can be just a symptom of Parkinson's. Your mood can be perfectly fine and you can still have fairly significant apathy. Hallucinations can occur, usually visual. Sometimes there's a sense of presence, we call it a sense of presence. There's this feeling that somebody's sort of hovering back here behind you. You might see things flit by in your peripheral vision, but often it's visions of seeing people somewhere. Again, these usually occur later in the disease and can sometimes be a side effect of medications. But again, generally people with later disease, like 10, 15 years in. Sleep disturbances are very common. So initial insomnia, trouble falling asleep, frequent waking up through the night. And there can be many reasons that people have disturbed sleep. So one thing is that levels of melatonin are low in the brain. So melatonin, you may be familiar with it. You can buy it over the counter as a sleep aid. So melatonin is a hormone that makes us sleepy. So around bedtime, the brain releases melatonin, it makes us sleepy. The levels are low in Parkinson's disease. Sometimes people will have a tremor that keeps them awake, or they start to get stiff and develop pain in the middle of the night. Sleep apnea is more common in people with Parkinson's disease and can disrupt your sleep. Restless legs are more common in Parkinson's disease. Some people get leg cramps. Lots of things can affect sleep in people with Parkinson's, and one of our jobs is trying to figure out, okay, well, what is it that's interfering with your sleep, and what can we do about it? I mentioned melatonin is low, so the circadian rhythm or the body clock that regulates when we're sleepy and awake is dysregulated. And similarly, that mid-afternoon wall that most of us are familiar with tends to hit people with Parkinson's like a truck. So some people find they just have to have a nap at 2 or 3 o'clock because that normal sleep-wake cycle is just a bit dysregulated. Ahead of myself here, the slides, and yeah, fatigue also is a very common symptom and can be a primary symptom. So even people who are sleeping just fine may have issues with fatigue, which can be quite bothersome. And some of that is because of the other symptoms. So, the fine movements are clumsy, so it takes you forever to, get your shoes tied and get your socks on, get dressed. And by the time you've struggled through getting dressed, you've used up all this energy and it leaves you feeling tired. So there's lots of things that can play into fatigue as well. And then we mentioned REM sleep behavior disorders. So people start to act out their dreams. Most of the time that's more bothersome to the bed partner of the person with Parkinson's because it keeps them awake. And occasionally people will get punched or kicked because, you're asleep and can't control what you're doing. But we always screen for these sorts of things. So autonomic dysfunction. So the autonomic nervous system is sort of the part of the nervous system that controls what we call sort of housekeeping functions. So it's the part of the nervous system that regulates your heart rate, your body temperature, your bowel and bladder function, that sort of thing that aren't under voluntary control. So this is disrupted as well. You mentioned, constipation can be one of the earliest signs of Parkinson's disease. People commonly will have issues with bladder function. So typically people will pee more often and have urgency. So when you gotta go right now because the bladder is hyperactive and you develop an urge to void, to pee when the bladder isn't as full as maybe it once would have been. Blood pressure regulation is also commonly affected. So any of us, when we stand up quickly, if you're haven't been as diligent about your fluid intake, you can get a bit lightheaded. That can be a symptom of Parkinson's as well. And many of the medications we use to treat the symptoms of Parkinson's make this worse. And so that's something that we always think about as well. People don't usually have issues with cardiac function. There are changes with the innervation of the heart that can be detected on sophisticated tests, but people generally with Parkinson's don't have heart or lung, clinically meaningful heart or lung issues from Parkinson's disease. People will often have dry eyes with Parkinson's, but not because of any problem with tearing, but because people with Parkinson's tend not to blink as much. And when we blink, we spread tear film and hydrate the eye. So if you're not blinking as often, the surface of the eye dries out. So using artificial tears can help with that sort of thing. So lots of different things can fall under this category. Cold hands and feet, very common. Not anything to worry about, but definitely a nuisance. Lots of people complain about that. And then something we don't talk about nearly as often as we should, admittedly, is sexual dysfunction. Very common with Parkinson's in both men and women. So erectile function in men, lubrication in women, sexual desire can be affected. These things are treatable. So if your doctor doesn't bring it up, don't be shy about bringing it up yourself, as these are, again, common things that have major impact on quality of life. And then other symptoms. So pain is very common with Parkinson's disease. And there can be lots of different reasons why people with Parkinson's have pain. You see people with who are taking medications, for example. Sometimes people, when their medications wear off, they'll develop weird tingling or weird tightness that goes away when you take your next dose of medication. That's fairly common. And then people with Parkinson's are more likely to have issues with musculoskeletal issues like tendonitis, bursitis, arthritis, that sort of thing. And the way that I think about it is Parkinson's is an asymmetrical disease. So it always starts on one side, it always spreads to the other side, but one side's always worse off than the other. And so your left and right are not really totally in sync. And that puts different stresses on your joints than usual. So you're trying to compensate for the fact that you're dragging your left leg, and that puts a little more strain on the right side, for example. So it can flare up arthritis and things like that. And then, cognitive changes are also quite common, unfortunately. So the majority of people with Parkinson's disease will eventually develop some degree of cognitive dysfunction. So if you follow people for 20 years, the best data we have is a study from Norway that followed people for 20 years. And at the end of 20 years of follow-up, 80% of people had cognitive impairment. The younger you are when the symptoms start, the less likely you are to have cognitive impairment. But it is something that we have to watch for most people. Okay, so that is what I had today. So we have now about 20 minutes for questions. Obviously, there are other symptoms that people get. We've tried to go over some of the more common ones. This is my dog, just to make things a little bit more lighthearted after the heavy talk of Parkinson's symptoms. So I will, just a plug that our wonderful nurse practitioner, Joanna, will be giving the next talk next Tuesday at 10:30 about treatment of all of these horrible things that I've just talked about. So I am going to pull up the chat here. If you've got any questions, just put them in the chat bar or chat box, and I will go through and answer them as best I can. The first question here is, I've heard that we should not take dopamine supplements. So that depends a little bit on what you mean by dopamine supplement. So Joanna will go in more into treatment, but the gold standard treatment for Parkinson's disease is a medicine called levodopa. And this basically is a dopamine supplement. So levodopa is a naturally occurring compound. When our body is making its own dopamine, the step in the pathway before dopamine is levodopa. So we give it to you in a pill. Dopamine itself isn't terribly stable. It's not very bioavailable, so it's hard to absorb it. It doesn't stick around for very long. Breaks down very quickly. So we give this sort of precursor to dopamine. Your brain turns it into dopamine and sort of restores a lot of the function. There is a supplement called Mucuna pruriens out there that naturally contains levodopa that's promoted widely been used in Ayurvedic medicine for a long time. And many people use that. And often I think physicians will recommend that people steer clear of it, more because it's really hard to get a good supply. So in North America, when they look at the commercially available preparations of mucuna, the actual content of the active ingredient ranges anywhere from 5 to 150% of what it says on the label. And it can vary from batch to batch. So you never really know what you're taking. Taking the dopamine doesn't affect the disease process in any way. It's just a symptomatic treatment. And the studies that have been done with mucuna, it has been studied, it is effective, but it's really been looked at as a low-cost alternative to levodopa for use in the developing world, because it's from a bean, it's cheap to extract it. Basically, there's no advantage to one over the other. And in North America, the mucuna is many times more expensive than the pharmaceutical grade levodopa. And so there's really no advantage to taking it. And you never really know what you're taking. So it's really hard to know how to dose it. And so generally speaking, we recommend avoiding it because there's not really any advantage to it. But if you could find a reliable source of it, it does work. It's just quite expensive. I feel cold all the time, any relationship between temperature and body, brain, and movement. So potentially, like I said, hands and feet, most people most commonly complain of cold hands and feet, but certainly the autonomic nervous system that helps regulate body temperature and temperature sensation is affected. So it could be related. Having said that, though, it's a more common thing would be a thyroid problem making you feel cold all the time. So it doesn't hurt to just touch base with your family doctor to make sure there's not something else contributing to that. So someone asked, is it safe to take over-the-counter melatonin? I did just see, I think last week or the week before, there was an article in the lay press about over-the-counter melatonin. As far as I'm aware, in the context of Parkinson's disease, there's not much concern. Melatonin is actually the first-line treatment for REM sleep behavior disorder. And I've had a few patients with REM sleep behavior disorder injure themselves fairly significantly. You hear occasionally people injure their bed partner fairly significantly because you're punching and kicking and can't control what you're doing. So as of right now, for people with Parkinson's, I'm not aware of any particular safety signal for melatonin. We generally recommend not going above 12 milligrams, however. I know some people take quite a bit more than that. So any beneficial supplements, right now, there unfortunately haven't been any supplements that have been demonstrated to be effective for people with Parkinson's disease. There are lots of studies about supplements. Most of them, well, all of them that showed a benefit that I'm aware of were on animal models of Parkinson's. And unfortunately, when they've been studied in humans, they haven't shown any benefit. So, animals don't get Parkinson's disease. So we either splice in human genes that cause Parkinson's, or we poison them with certain things that kill off the similar populations of brain cells that die off in people with Parkinson's. But those models don't really capture Parkinson's disease. And so the models are really good for testing symptomatic treatments, but they have not been that helpful so far in finding things that actually going to affect the course of Parkinson's disease. And so unfortunately, every supplement right now that's been studied has not been effective so far. Having said that, this time of the year, probably all of us should be taking vitamin D, but just for general health. And it may have some effect on Parkinson's, but that would be the only thing that would be routinely recommended. How can I get more out of my day instead of feeling tired and watching TV? So I think Michelle will address that in a couple of weeks. Some of it is hard to get motivated, but regular exercise does help improve energy levels, helps with sleep, helps with mood, actually helps the symptoms of Parkinson's disease. So the single most important thing that you can do is to exercise. Joanna and Michelle will talk about this, but we don't know if there's a best exercise. My personal bias is that if there is a best exercise, if you don't like it, you're not going to do it. So you might as well just find something that you like to do. Go for a walk, do yoga, ride a bike, stationary bike, what have you. Something that's going to get your heart rate up just a little bit, but you don't need to be gasping and panting for air, just to get your heart rate up a little bit. When and why should you start medication? So that, Joanna's going to talk about that in some detail next week. So I'll defer that question for now. We are going to have another Q&A in 2 weeks. So if there are still things about that that aren't really clear, then please feel free. I just don't want to steal Joanna's thunder for next week. Does tremor usually start on your dominant side and progress to the other side? Good question. The tremor usually starts, well, Parkinson's symptoms start unilaterally. If you have symmetrical symptoms from onset, that is one of those red flag features that we think, okay, well, maybe this isn't Parkinson's disease, it's something else. The side that it starts on seems random. So it does not always start on your dominant side, but always will progress to the other side. And similarly, if your symptoms never go to the other side, then you probably don't have Parkinson's disease. Sometimes it can take several years, but the symptoms always progress to the other side. But the side that it starts on, as far as we know, is random. Any surveys on how many had overexposures to different pesticides when younger? There are epidemiological studies that do show a link to certain pesticides. It's mostly agricultural workers who are actually applying the pesticides that seems to be the risk. It doesn't seem to be pesticide residue on food, as far as we know. But again, it's really hard to link things, that exposures that may have happened 40 years ago, to symptoms that someone is having today. So that is a challenge, but there is that association for sure. I had constipation over many years, and now my bladder, I feel, is acting up. I was diagnosed 4 months ago and I'm 80. Exactly. So constipation can be early, and there's been some data recently that people with irritable bowel syndrome are more likely to get Parkinson's disease than others. And there's some interest in what role the gut microbiome might play in developing PD. So the bacteria, the viruses, the fungi that live inside all of us in the gut, there's some interest in what role those might have to play in developing PD as well. And maybe pesticides affect the microbiome, for example. If the microbiome is a bit out of whack, maybe that contributes to constipation, and that's how things start for some people. So it's lots of intriguing stuff going on. Is late incontinence not knowing about urine leak part of Parkinson's? It can be, unfortunately, again, with that urgency. Usually people will still know they need to go. It's just you may not have much warning. You may only have 30 seconds to get to the bathroom once you feel the urge. Loss of any, if you don't know at all that you even need to pee and you find that you've peed, that can be something different, and you should talk to your doctor about that just to make sure there's not some other problem going on as well. I'm hot all the time. Again, people not uncommonly complain of drenching sweats and feeling very hot when their medications start to wear off. So if that's something that you notice, we focus a lot on the motor symptoms with Parkinson's, but many of these non-motor symptoms are very prominent. And the non-motor symptoms can also fluctuate with medications, just the way we talk about motor symptoms. Sort of getting into next week's topic a little bit, but if there's a pattern where at the end of the medication dose you get very hot, drenching sweats, it's probably from the meds wearing off. So I feel changes in my body all the time, in the hips, knees, the way my feet want to land on the floor, my neck feels hard like a rock. So for sure, Parkinson's can affect all of that stuff. People are also allowed to have more than one problem. So as we get older, we all have more problems with arthritis and different aches and pains and things like that. So sometimes you have Parkinson's on top of other stuff. Michelle, I think we'll talk a little bit about some of this stuff. You can work on your gait to try to make that a bit better. But some of it is having to be a bit conscious of how you walk. And we think that if you're a bit mindful about it for a while, maybe you can use neuroplasticity to try to sort of retrain and make a more normal gait a bit more normal and a bit less effortful. And working with a physiotherapist or trainer who knows about Parkinson's can be helpful with that as well. CBD oil, so I think Joanna will address that next week, so I'm going to defer that to her. How much body strength, flexibility, and coordination can be maintained. I think regular exercise is the most important treatment for Parkinson's. Of course, strength, flexibility, and coordination all decline as we age, even for healthy people. So it's important to keep up with that. And again, I think Michelle will address that a lot in a couple of weeks. Could sarcoidosis be a problem? So sarcoidosis is an inflammatory disorder that can affect many parts of the body. There really isn't a link between sarcoidosis and Parkinson's disease. So I'm not sure if that really addresses the question, but they're completely unrelated disorders. Sarcoidosis is quite rare, but Parkinson's is relatively common. And so it's certainly possible that someone could be unfortunate enough to end up with both. What can I do for going to the bathroom so much at night? So I think Joanna will mention that a bit next week. The easiest thing in the short term is this might sound a bit trite, but to try to limit fluid intake after dinner time. There are medications that one can use to calm down an overactive bladder if it's that bothersome. But not drinking too much after dinner time and then going pee right before you go to bed, making sure the bladder is really empty. They're probably the easiest thing in the short term. Any link to welding? Welding is interesting. So there have been contradictory results from welders the last time I reviewed this. One concern about it is that manganese, which is a metal, has been linked to, manganese toxicity has been linked to Parkinsonism, not Parkinson's disease, but manganese can accumulate in the brain and cause Parkinson-like symptoms, and welders are often exposed to manganese. So you would think that they would be at higher risk. Some epidemiological studies have shown welders are more likely to get Parkinson's, but most have actually shown that welders are less likely to get Parkinson's than other people. So it's really not clear at this point what role it has to play, but it does not seem to be a major risk factor. Okay, so I think what kind of cognitive, I missed one question here. What kind of cognitive symptoms does recall change? Not being able to remember things that you usually remember. Good question. So with Parkinson's disease, so first of all of us will notice cognitive changes as we age. That is completely normal. So the things that we expect to see as we age, and by age, I mean like anyone north of about 40, is that your processing speed slows down. So it takes longer to work through things. Multitasking becomes more difficult, and word recall is problematic, particularly for names. So the words on the tip of your tongue will not come to you, and then maybe like 3 o'clock in the morning, bang, Meryl Streep. That is normal for everybody. Parkinson's can take that and run with it. And then additionally, people will have issues with visuospatial processing. So understanding, being able to process where one thing is in relation to another, relative distance between the two, where one thing ends and the next begins, which can have implications on people's ability to drive, for example. Recall is affected, not to the degree that you see with Alzheimer's disease. So with Alzheimer's, the most prominent symptom is memory, asking the same question over and over again, just can't form new memories. With Parkinson's disease, people can usually form new memories. It's just finding them that's difficult. So if you provide cues, people will be able to retrieve the memory more easily. Language function can change a little bit, finding the words, that sort of thing. But that's sort of the cognitive profile that you see with Parkinson's. A bit different than with Alzheimer's. Should we continue to drive? Driving is a very good question. And it's not really an easy one to answer. So Parkinson's does affect people's ability to drive eventually. Many people with Parkinson's are able to drive without difficulty. But there are two things that impact driving. One is cognitive, as I just said. So if your brain is having trouble figuring out how far that kid who's about to run into the street is from you, that has obvious implications. And then your reaction times are slowed, just because Parkinson's makes everything slow, right? So it becomes a bit challenging to know when those symptoms have gotten to the point where you can't drive. So we do cognitive testing, and if there's, one of the things that you're asked to do in most cognitive tests is to copy a shape. If your brain isn't able to figure out how to copy the shape, it tells us that there's a problem with knowing how things are oriented in space and where things are in relation to another. And then we might say maybe driving's not a good idea. Often the best predictor of when someone shouldn't drive is if your family has concerns about your driving. So we'll ask people, would you let grandma or grandpa drive with the grandkids in the car? And if the answer is no, then we'll probably say maybe you shouldn't drive. Ultimately, it's up to ICBC whether you can drive or not. We, as physicians, have sort of been given the task of screening and identifying problems, but it's really ICBC that are the final arbiter. And if you disagree with your doctor, you can always take a road test, right? But most people, I think, scale back their driving, and it's not always an all or none. It can be that your doctor might say, well, I think it's okay if you drive familiar routes in the city, stay off the highway, don't drive in the dark, don't drive when it's raining, that sort of thing. So it's a bit of a complicated question. Lewy body. So Lewy body, there's a condition called dementia with Lewy bodies. I'm not sure if that's what you're asking about. It very closely mimics Parkinson's disease. The biggest difference between them is that the cognitive problems are early and prominent, whereas with Parkinson's disease, the cognitive problems tend to start a bit later, but it's really a little bit of a continuum. It's a bit debatable whether they're really separate diseases, basically. Okay. Oops. I have recently been diagnosed with mild PD, but I have severe apathy and severe balance issues. These are always listed as being in advanced stages of PD. Yeah, so usually if we see severe balance issues early on, that's one of those things that make us think, do you have Parkinson's? Having said that, again, you're allowed to have more than one problem. So again, I don't know your particular circumstances, but if some people have other conditions that might impact their balance as well. And so the question, I guess, is whether the balance and the Parkinsonism are caused by the same thing or different, and that you'd have to talk with your doctor about. And then the apathy can kind of happen anytime. It is much more common later, but it can happen sometimes early. The apathy on its own wouldn't be as concerning as the balance issues in terms of maybe something else than Parkinson's is going on. Okay. So.
And I think, Jonathan, Susan has her hand up. I think she wants to ask a question. I'll unmute her.
Great.
Go ahead, Susan. You'll have to unmute now. Susan, did you have a question? Maybe she just raised her hand by accident.
Okay. And I think Elaine.
Oh, now I see two participants raising their hand.
Yeah.
Okay, Elaine. Go ahead after you unmute.
Unmute.
Hi, Elaine. Did you have a question?
Hello, can you hear me?
Yep.
Okay. My husband and I are together listening to you, and he has a question with regard to the fact that he has developed a very strong smell sense towards chlorine from the tap, but he can't smell anything else. He's been diagnosed, or he's been without smell for maybe about 10 years.
Not completely, just occasionally I get some smell. But not very often.
But
anytime I go to the tap now with the running water out of the tap, I get this strong. I mean, it's stronger than I ever remember.
Okay. I'm not sure exactly how to explain that. I have one or two other patients who develop weird smells like that, either hypersensitivity, or one person actually just has a phantom smell. I honestly don't know what the what the answer to that is, but it can happen, but it's one of those weird things.
Oh,
Okay.
all right then, thank you.
Sorry.
That's
So
okay.
more helpful. And I see Tracy here says, if you have a tremor and no bradykinesia, then you don't have Parkinson's. That's right. So the defining feature of Parkinson's disease is not the tremor, but the bradykinesia, so the slow movement. There are other conditions that can cause tremor. The most common would be essential tremor, which is more of an action tremor. So when you're trying to use your hands to do things, the tremor is more severe. There is the odd person with Parkinson's disease that starts out looking like that. And you think reading about essential tremor and Parkinson's disease that they're very different diseases and should be very easy to tell apart. But when they're bad enough, they actually can overlap quite a bit. And so it can be a little bit difficult to tell them apart sometimes. But generally speaking, yeah, if you don't have any bradykinesia, then by definition, you do not have Parkinson's disease.
Okay, so we are just approaching 11:30 here. I think that was the last question. Dr. Squires, I want to thank you so much for sharing your expertise with us today. And thank you all for attending. I'll see you at the next talk in the series, where nurse practitioner Joanna Davis will be speaking on treatment in Parkinson's.
And I will be seeing you in 2 weeks from today as well. All three of us, I think, will be at the question and answer session. So if there's not something that's still not clear, then we can always address your questions then too.
Yes, that's right. And that panel Q&A will be 30 minutes long.
Mm-hmm.
So you'll have a bit more time. Thanks again.
See everybody soon.